Kind cowboy, sir, I need your assistance. I've coming from Europe, and I'm on this medication, Dabigatran, and I have unfortunately been kicked in the head by a horse, and I'm bleeding, as you can see. There's a lot of blood coming from this laceration on my forehead. Sir, can you help me?
I can help you. I mean, since we're out here on the prairie, not a lot I can do. I don't have a CAT scan. I don't have any medicine. Old Cookie's got some rawhide stitches, maybe a little cowhide poultice. I could push on it with my hand, but if you're looking for anything fancy dance or even a CAT scan, I'm afraid you're SOL, my friend.
But, kind sir, according to the 4 volumes of Glun that I have, it says that there's some sort of medication that maybe you can use to stop this bleeding. I do say rawhide and stitches, they will not look good with my wig.
Yeah, that medication, that is shrouded in skepticism, controversy, conflict of interest, small studies without any true clinical outcome, maybe a little bit of bleeding. I'm skeptical. Maybe it works. Pretty safe, but I'll tell you this, I don't have any. But if you want some pork and beans, we got some in the covered wagon.
Well, what says the good Dr. Morrison then?
All right, well, let's talk about it. You're talking about the drug Dabigatran, and more importantly, what do we do to reverse it in addition to pork and beans? Let's dive right in. So Dabigatran, right? This is one of the NOACs or DOACs that has come onto the scene in the last decade or so, and we like it because it's easy to prescribe for patients, but it has had its issues. This was first approved in 2010 for the prevention of ischemic stroke and systemic embolization, but it's not completely benign. It has a bleeding risk of 16%. That's not tiny. And 1.5% of life-threatening bleed. So this can be a problem, and sometimes we need to reverse it. Now, historically, we didn't have much. Well, we still don't have much, but that's controversial. We'll get into that in a moment. But the lack of a direct antidote left minimal treatment options. So we would initially give some hemostatic agents like FFP or PCC or factor VII. And ultimately, sometimes we would even need to hemodialyze these patients. Until this drug came on the market, Idarucizumab. And this was the first, quote, reversal agent specifically designed for Dabigatran. Now, what is it? It's a humanized monoclonal antibody fragment. It actually binds to the thrombin site 350 times more affinity than thrombin. It does have a short half-life. And the good news is we don't think it actually increases your risk for hypercoagulability, right? Which is the main concern about reversing someone. So yes, they're bleeding, but you also don't want to overshoot and make them hypercoagulable. This paper reviews 5 original research articles. We're going to talk about these because there's a little bit of controversy with them, but let's just go with it. So we're going to go through each paper, starting with the first one. Now, I want you to look at the author's last name, Glund et al. You're going to see this over and over and over again. This first paper was published in 2015. It was a phase 1 double-blind randomized control trial. And it included 110 patients, and they looked at basically the effect of various coagulation parameters. They're trying to ask the question, does this medication, Idarucizumab, change the coagulation parameters on patients? And their conclusion was Idarucizumab has no significant effect on coagulation parameters or endogenous thrombin generation potential. The rate of adverse effects were similar between both study groups. Moving on to the next paper, look at the author again, Glund et al. Again, this time in Lancet 2015. And again, another phase 1 double-blind randomized control trial. This was smaller, only 50 patients, and they looked at whether the incidence of drug-related adverse events and reversal of multiple coagulation parameters occurred. And they concluded that Idarucizumab demonstrated immediate reversal of Dabigatran-related elevations of multiple coagulation parameters. Okay, we're going to take this with a grain of salt. We're going to talk about this at the end. Number 3, third paper, same author, Glund. Dr. Glund loves his Dabigatran and Idarucizumab. This one was in 2017. Randomized, double-blind crossover study this time. Very small, 28 patients. 18 of them had mild to moderate renal impairment. And the reason that's important is because they wanted to know the safety of Idarucizumab for the reversal of Dabigatran in elderly patients or those with renal impairment. And what they found was Dabigatran-related coagulation parameters were all reversed back to baseline, regardless of renal function or age. All right. Number 4, look at the author again, Glund. This guy's a machine. 2016. This is a tiny study, 12 patients pre-treated with dabigatran for 4 days. And they wanted to know if Idarucizumab reduced dabigatran levels and normalized coagulation parameters. And what they found was they gave the placebo or Idarucizumab after their last dabigatran dose, and then they compared. And Idarucizumab provides an option for rapid reversal of dabigatran-induced anticoagulation and allows for reinitiation of dabigatran 24 hours later. That was a pretty big conclusion that they came to, and controversial for a few reasons. And for the fifth paper, this is the first time you see that Glund isn't the primary author. This one was published by Polak in 2016, and this was a prospective cohort study assessing the safety and efficacy of Idarucizumab in adults presenting with serious bleeding or need for an urgent procedure. It's a decent-sized study. They used 90 patients. 51 of them had serious head bleeding, like head bleeds, GI bleeds, trauma. 39 of them actually required an urgent procedure. They were given 5 grams of Idarucizumab to try and reverse them, and the results were interesting. The median maximum percentage reversal was 100%. And their conclusion was that Idarucizumab rapidly and completely reversed the anticoagulation caused by dabigatran, and no safety concerns among the 90 patients studied occurred. Now, here is my question to both of you, is that there is a lot of biases with these 5 papers because unfortunately, both Glund and Polak, would you know, worked for the company that produced both dabigatran and Idarucizumab. Not only that, that's a major problem, right? But both drugs, both dabigatran and this antidote, Idarucizumab, are both created by the same drug company as well. So not only is the same company creating both medications, but the authors of these studies and the researchers worked for these industry-funded companies. So there's some significant biases. There's some controversy as well that only one article actually assessed a clinically relevant outcome of hemostasis. All the studies were pretty small. And there's a question about whether Idarucizumab actually works to reverse dabigatran, or is it just due to the fact that dabigatran actually has a pretty short half-life? So in summary, Idarucizumab so far does seem to have a pretty safe, side effect profile. And so sure, in de Klerk's case of having an internal head bleed or a massive trauma, should you give it? You should, because it looks like when you're weighing risks versus benefits of dabigatran, giving Idarucizumab is fairly safe. So if you have a life-threatening bleed, sure, you should give it. But understand that the existing data is limited. It seems safe, but we definitely need larger studies with unbiased investigators, preferably. Now, here's a question for both of you. Let's say you have a large laceration to your arm or leg, and we know that the patient's on dabigatran. Before you reach for Idarucizumab, what else can you do for that laceration you got on the arm or leg?
Just push on that puppy. Push on that puppy right there.
Yeah. And what would you do after direct pressure? Let's say you're still oozing. Couldn't you throw some stitches in? If you can topically treat a bleed, an external bleed, then yes, I would still say start with those basic things first before you reach for these reversal agents. Because if you don't have to reverse them, you don't want to. There's always risks and benefit involved.